of children with we are seeing a lot of children with high screen time exposure, nuclear families where both parents are working, and there's been a better awareness all around families and even with the pediatricians. So I think all the pediatricians who are here would agree with me. The footfall in the children who are presenting with delays in language have definitely increased. And whether they are fitting into spectrum or just language delays, we are going to do a little more case-wise discussion and cover all these topics as much as possible in this short time. But before I start to the cases, we have to understand certain terminologies which we use very commonly when we talk about children with language delay, and which is communication, language, and speech. So they may sound similar, but they are definitely not interchangeable. When we talk about communication, it is simply communication is a two-way process which is taking place with two people, exchange of information between two people, which is a social form of connecting with each other. It has to be meaningful. It can be a non-verbal communication where a person may just do a gesture or may speak and the person understands. And so there is a to and fro part, and two people have to be involved. That's the main highlight when we talk about communication. But when we talk about language is more of a defined code or a structure or a convention we follow when we talk about language. For example, if we say apple, A-P-P-L-E, means a red fruit in English. We cannot call apple a ball. So it is a code which we have to follow. Similarly, we have many languages. It can be English, Hindi, it can be Marathi, Spanish. It can even be a sign language, which is again a definite code which we are following. But when we talk about speech, speech is largely the spoken language or the expressive part of language we're talking about. So here, when we talk about communication, language, speech, we may interchangeably, but they have a definitely different connotations, each of them. So with this, I start with my first case. And this is a child who was 12 months old, and the child has been brought with the concerns of the child at 12 months is not responding to name. Parents are not very sure whether the child is responding to certain sounds or not. Child does smile and interact with the parent, like through some non-verbal communication is there. He also copies few actions when the parent says, do this, or does the gesture the child may copy, bye-bye. Child does make few sounds like which may appear like babbling, but the child doesn't have any meaningful word as yet. In the birth history, the child was a term baby who had a delayed cry, required oxygen for 2 days. After that, all was well, feeding well. And the OAE was done, which is done in most of the hospitals now in our city, and the OAE done, which was normal at birth. Now, I would like to ask Dr. Neha here, what do you think? How do we proceed with this child? Since the OE was done at birth, is there a point in doing another audiometry test? And can you just also elaborate the role of OE versus BERA versus ASSR?
So, a child who was born with a delayed cry and, some problems at birth, sometimes you would, as an ENT person who's treating hearing loss, you would keep that child under supervision. But yes, if the OA is normal, generally you would not expect anything to go wrong because, but finally, OA is a screening test. It is not a confirmatory test. If the child is not making any meaningful sound by 12 months of age, then yes, that child needs to be kept under observation or maybe even re-evaluated if there has been some problems at birth. But some children definitely do start these talking or learning these few words a little late. But yes, these children should be evaluated. See, I think we can start by doing a OAE first, and maybe a OAE can be screened again. But yes, sometimes with some problems like auditory dyssynchrony, OAE can still be normal, but the child might still have a hearing loss and would still not be hearing. So there is no harm keeping the child under observation before you even do some kind of other test. So this is the gray area, because where you want to do a test like a BERA at a 12-month-old child, or wait for some more time to learn a few words, or you can go ahead and do a BERA, because these days the international guidelines do say that there is a 1-2-3 rule. Initially, there was a 1-3-6 principle, which meant that screen at 1 month, diagnose by 3 months and treat by 6 months. So now it has become 1-2-3. That means you diagnose, sorry, you screen by 1 month, you diagnose by 2 months, and you treat by 3 months. So if you need to put a hearing aid on a child, it should be done by 3 months of age. So if aggressively we are treating, then yes, a BERA needs to be done. OA still will not be sufficient. And like the second question which you asked was, what is the difference between a OAE and a BERA and a ASSR? So in simple terms, OAE is just a screening test which can tell us the function of the hair cells. So it can give you a false positive result also sometimes, and a false negative result also sometimes. That is why when we are screening at birth and we find a negative result, we repeat the test after 1 month to see whether the OA is still negative, is refer, or is it passed now. And sometimes we often see this, that sometimes there is fluid in the ear, or there is middle ear fluid because of in children, and that is why it comes as a refer result. And when we repeat it, it comes as positive. So OA is just a screening test. BERA will give you the threshold levels at which the child is hearing. And the difference between BERA and ASSR is ASSR, it gives you the threshold levels at every frequency, like the audiogram we do in adults. So ASSR will give you the threshold levels at various frequencies without actually doing an audiogram in these children. So at 12 months, yes, ideally, BERA should be done so that you know for sure whether the child is hearing or not, and you can then plan your treatment the way you want to plan it.
Right. Thank you, Dr. Neha. From a clinical practice point of view, I just wanted to know, when we talk about BERA in a child where we are suspecting a delay in the language or a hearing impairment, do we specify, is it a screening BERA or a detailed BERA? And like from a clinical point of view, how do we proceed for that BERA test? Like, I believe there is a screening BERA and then there is a detailed evaluation.
And BERA, we would do as a confirmatory test, as a diagnostic. The BERA is a diagnostic test. BERA will not be done as a screening measure. For screening, we just do OA.
Right.
When we want to actually, when we are suspecting hearing loss in a child, that is the time we would ask for a BERA, and it will be done as a diagnostic test. It is a confirmatory
Done
test.
across all the decibels, like not just 1 decibel, because I think sometimes we tend to see in our practice the report where a BERA has been done only at a higher decibel, and so
So
obviously
check at what level you are getting a response, whether all waveforms are complete or not. And even in neonates, where ideally a BERA should be done, where there is a high degree of suspicion. So screening is done for every child, but all children who have been in the NICU or have had a history of jaundice at birth or kept in the ICU for a longer period of time, ideally international protocols say that they should, you should leave OA and you should directly do a BERA in such children, because there is a high chance of these children having a hearing loss. So instead of a screening test, a diagnostic test should be done in such children. Hello? I think you're... Hello?
Looks like Dr. Shambhavi has just maybe got signed out. She may join back.
Yeah, yeah.
So I'll just add on to the Dr. Neha, you said at 3 months, then the hearing aid is a good idea. That's what you're trying to.
If at suppose if a child, we find out that a child is has severe to profound hearing loss. So at 3 months, that child is the ideal candidate for cochlear implantation. But 3 months is not the ideal. Sorry, 6 months is not the 3 months or 6 months is not the ideal age for a cochlear implantation. The rule now is 1 to 3. What I said was treat by 3 months. So you cannot do a cochlear implantation at 3 months of age. You still need a good skull thickness, or a child at least 6 months of age, or a particular weight for a child to undergo anesthesia and surgery. So till that time period, till the time we cannot do an implant, that would be at least 9 months of age, we want to give the child hearing. So we put in a hearing aid in such children, and so that the auditory stimulation starts and auditory stimulation continues till the time we can do a cochlear implantation in such children.
What is a good age for cochlear implant usually?
So internationally, it is even done at 6 months of age. In our country, 9 months. The earliest we have done at our center is 1 year of age.
Sorry, I think I just got locked out because of the network issue.
So we were just talking about what is the ideal age for a cochlear
Right.
implant.
So I just wanted to also ask Dr. Neha, how do you kind of prognosticate and work up for a child with cochlear implant? Like what all, as a pediatrician, we have to see before we advise implant to a child?
So what you mean is that when we know that we want to do a cochlear implantation in a child, what are the other prognostic factors? So your assessment is one of the very important factors in all our children. That is one. First of all, we need to see, when we know that there is a severe to profound hearing loss and the child is an ideal candidate for a cochlear implantation, we want to know what will happen once we do a surgery and the child starts hearing. Our purpose is not just hearing. Our purpose is the child should be able to understand and learn how to speak. And for that, we need to know, we send all these children to your department. One of the pediatrician has to see the child and see whether there are any other congenital malformations in the child. Is there any other genetic problem with the child? We send the child to the pediatric neurologist, that is Rajni, who does a complete assessment and neurological assessment. And all these children go to you for a complete developmental assessment. And we want to know how well is the child understanding and how well will the child do after a cochlear implantation. So a complete evaluation by all the people will give us a prognostic evaluation of the child and how well the child will do. If the child has no other abnormality and is behaviorally okay, there is no developmental issue besides because of the hearing loss, then we expect the child to do very well. And the prognostic factor, again, one more very important prognostic factor is what age is the child being implanted. So the earlier the child is implanted, better that is a good prognostic factor, because then the speech development is as good as normal. So a child who is implanted at 1 year have as good a speech as a normal child, and a child versus a child who's implanted at 5 years, because those 5 years he is deprived of any auditory stimulation, and the speech rehabilitation takes more time, and the speech is not as good as a child who is implanted at 1 year of age.
Great. Thank you so much, Dr. Neha. And from your case, I guess the key points would be when we talk about screening tool and OE as normal, it's a screening tool. But if we do see language concerns, even as early as 1 year of age in any child, we have to consider a detailed audiometry checking, which would include a detailed VERA at all decibels and even ASS.
Okay, Shambhavi, can you make it a full screen, please?
Okay, whenever required. And like you mentioned, the 136 rule has now changed to 123, where we screen at 1 month. By 2, we have a complete audiological evaluation, and by 3, we start the intervention. And like you mentioned, the prognosis will depend on the age it has been picked up, the development of the cognitive level of the child, whether any comorbid conditions are there. We have seen many children who have had hearing impairment and autism. So that becomes again, a thing to manage. And of course, the post-intervention follow-up and the care the child is being given. So thank you, Dr. Neha. Coming to our next case. Next case is a preterm baby who was born at 20 weeks, 28 weeks of gestation with a birth weight of 1 kilo, had a stormy NIEC course. There was a history of seizures and the child had received phenobarb and valproate. MRI was done in first year of life, was suggestive of a periventricular leukomalacia. Now the child is come to us at 2 years of age. On history, the parents have said the child had delayed sitting almost at 10 months. The child started walking independently at 2 years of age. The child doesn't still have any meaningful vocabulary or words, though the child responds to name and follows few simple instructions. The parent, on advice of pediatrician, had started occupational therapy at 9 months of age. So I would like to ask Dr. Rajni, our pediatric neurologist, about this case where the child had, what could be the likely cause of language delay in this case, and could this have been picked up earlier, and could you elaborate a bit about development screening in high-risk newborn? Dr. Rajni?
Hello.
Yeah.
Yeah. Am I audible?
Yes, you are.
Yeah. So since we know that the child is a preterm and is a high risk case, first thing is that we should have been kept the child on developmental screening. And once we keep the child on development screening, we obviously will see the child intermittently, do a screen on about all the developmental milestones about the motor, cognitive, socio-cognitive. And during those screening times, if you find that there is a strong defaulting, you would investigate or do some specific interventions. In these cases, where we get language delay, predominantly more than the motor component, here, because the child is high risk, because the child had global developmental delay, maybe because the child was not stimulated much on the language ground, or therapies has not been intervention had not been done for the language and socio-cognitive milestones, the child would have had language delay. Now, the important other reason can be hearing deficit. Obviously, when you deal with a child who has language delay, first and the foremost thing is first confirm whether the child is able to listen or not. So if you're clear that the child is able to listen, then you want to understand that why the child is not improving on language milestones. So either there is poor stimulation, there is high screen exposure, or just as a part of global developmental delay, the child is going slowly in terms of motor as well as socio-cognitive and language milestones. So these are the common reasons in a child who is preterm. Now, the other thing is about developmental screening, which I had put it earlier. The child who is a high-risk baby. So there are a number of guidelines which says that the children who are high risk, the preterm children who had been ventilated or had a stormy neonatal course or had a history of hypoglycemia or IVH. Basically, the children who are into the nursery, they can be categorized into mild, moderate, and severe categories of high risk cases. And then the intervention, depending upon the severity, should be started as early as inside the NICU. So within the NICU itself, early stimulation process should be started. Parents should be guided for the need for regular follow-up and then the long-term follow-up. So obviously, when we do these kind of stimulation practices inside the NICU, the results will be good because early intervention has been started. And it is not just the child. What we all want to enforce is that it is about the parental counseling. So you have to deal with the parents also. You have to explain that this is a long journey and the child will take time. It has multiple stages. These are the people you should meet regularly for the developmental screening. This is how you should keep the child home. These are the danger signs. One important thing which I feel in my practice is that the children, they usually come to me around 6 to 7 months when they start to have spasms, basically seizures. So some of these, they come very late to me. And then when I ask them that these are the jerks which is happening, some are so silent that they are not able to tell. So what if we explain them early while getting discharged from nursery, and then afterwards that these kind of spasms can appear in so and so time, and if it appear, please come early. We can do something if you come early. So these kind of guidance can be given preemptively. Like you have to explain them that these are the jerks which if come, you have to come early. These are the movements which are abnormal, you have to come early. And then these are the things you should do it regularly. So early intervention is not just infant, it is about talking to the family, counseling the family, and then depending upon the severity, following up the child.
Right. And I think in our practices, we have somehow seen when we talk about a high risk newborn follow up, lot of focus is started to give on physical therapies or occupational therapy. We tend to neglect the development of language milestones or cognitive milestones also for that matter. So it is also important to understand when we are following up, it has to be a very holistic overview of all the development skills. So talking of seizures, you mentioned Dr. Rajni. So sometimes, we do see children with language delays, and we tend to see if there is a history of regression, should we order a EEG? So what exactly is the role of EEG in a child with language delay? And as a pediatrician, should I be aware of any particular anti-epileptics which may affect the language development? Or what should we be monitoring in terms of seizure and a child with language delay?
So a very important question, Dr. Shambhavu. And here I would say that there are certain indications of doing an EEG in a child with language delay. So one, if we have a history of seizures vis-a-vis abnormal movements. Sometimes these kids have stimulus sensitive myoclonus. They will just show some kind of these kind of jerks on sound stimulation, on touch stimulation, and they will say कि बच्चा तो बस डरता है, बस ये थोड़ा थोड़ा चौंकता है. So that darna and chokna should be delineated whether these are epileptic or not. So any kind of abnormal movement and seizures, EEG should be done. Second, unexplained socio-cognitive delay, like by the virtue of the child, you are seeing the child holistically and you have done an MRI, and then you feel that the child has intellectual disability or socio-cognitive delay, which is out of proportion to the other milestone. Like in this case, language delay was much prominent than the motor delay. So in that case, EEG can be done because sometimes subclinical epileptiform discharges are seen. And the third thing is that if you see a MRI, for example, we see cystic encephalomalacia, then these are cortical lesions which has a higher risk of having seizures and subclinical epileptiform discharges. We do get an EEG done. Fourth and a very important thing is that if they have a significant behavior issues and sleep issues, they're not sleeping well, they have a change in behavior, I would say. A child who was normally calm suddenly has started showing aggression and hitting and not sleeping well. So if this is the time where you want to see whether the epileptiform discharges can explain this kind of behavior. So these are the important four indications. And when we do an EEG, we obviously will get the severity. That means in terms of epileptiform discharges, whether they are occasional, frequent, how is the background, we can kind of prognosticate that do we want to or not. Whether these EEG abnormalities can explain clinically or not. So though these are subclinical epileptiform discharges, but if treating these can help the children, we should start anti-seizure medications. And in most cases of prematurity or hypoxic sequelae or children who have structural deficit in MRI, we start anti-seizure medications so that we can control their behavior, sleep, and hope for a better development. Not exactly in all cases, if we treat, the language should come. This message should not go because in OPD we do not say that बस ये दवाई start कर देंगे and बच्चा बोलने लगेगा. So this is not the message. The message is that treating the epileptiform discharges or starting a medicine for epileptiform discharges may help them with sleep, may help them with better behavior, may help them better cope up with therapies and gain milestones. That is why we do start medicines. And the medicine which we should start depends upon the etiology. Suppose it is a structural injury, we can start sodium valproate, we can start phenytoin for that matter is also okay. But if you have certain metabolic or genetic disorders, you should think whether you want to start valproate or some other medicines. The choice of anti-seizure medication can depend upon multiple comorbidities and etiologies. But yes, in most cases with structural injury, we do start anti-seizure medication, even without having a clear clinical history of seizures.
Right. Thank you. And I think we have so many cases which we have discussed mutually also, where we have seen children with delays and some epileptiform discharges on EEG, and then we are wondering whether we should do or not. I think in each case, it's an individual discretion, and a team, if we are working and doing managing the language part, the development part, and the seizure part together, then it makes a lot of difference. So I think the key learning points would be a language delay may be missed, especially in high-risk newborn follow-ups, because the focus is so much on the motor aspect of the development. Holistic screening tools and a documented milestones for each areas is recommended. There are various training programs which are now available through IIP. We have a GRACE program which is done through the chapter of neurodevelopmental pediatrics, and there is an ECD program, which is a program from IIP. All these programs are available in the domain through IIP, which the pediatricians can get trained of and start implementing these easy things in their practice. And of course, like we discussed, EEG does have a role, but it is all individualized and specific cases. Thank you, Dr. Rashni. So now I go to my third case. This is a child who was at 3 years of age, brought with speech of few words, and the parents say the child mainly, used to speak some alphabets randomly, some parts of rhymes. Interested in the child used to follow instructions, but often related to the interest. Like if the parent would say ki chalo bahar ghumne chalte hain, child may get the shoes. The child seemed very hyperactive, but he had very good with blocks. Child was attending a preschool, apparently said to be good in academics, but very limited peer interaction. Birth was uneventful. The motor skills appeared good in this child. And this child already actually has been started on occupational therapy and speech therapy since last 2 months, and the family got to know about them through some online advertisements. 6 months prior to this, the child was shown to a primary pediatrician, also had recommended some interventions, and the told the family to consult a developmental pediatrician, which they didn't do that time. So for this case, I would like to welcome Dr. Sameer Dalwai. Dr. Sameer is joining us from Dubai, and he's a very well-renowned developmental pediatrician and a good friend. So to Dr. Sameer, I would like you to tell me, this child, the pediatrician is already feeling that the child is probably likely has autism, and the vision and hearing has been done, which is normal. So how does a pediatrician manage the child now? Does he refer to interventions? Does he wait because the child is already on some interventions, or anything more can be done from a pediatrician's point of view?
So good afternoon, namaste, and thanks, Dr. Shambhavi and BL Max Group for getting me an opportunity to interact with all of you. Thank you so much. Can I just share my screen quickly? I just wrote down some points.
Sure.
Yeah. So we've seen I'm just going to show some points to make it easier. And we heard that the child has speech of few words. What do we call that? We call that delayed speech. He says some words, but mainly alphabets and rhymes without meaning or without purpose. Sometimes with meaning, but always without purpose. So that is called as echolalia. Echo is, it's an echo. Lalia is speech. Now he does follow some instructions to allow to his interest. Bahar jana hai, chalo jute leke aao. But that's probably patterned learning. He is hyperactive, means he doesn't know what to do where, so he's always doing whatever his own thing is running around. We think it's hyperactive. It's probably poor social understanding of how to behave where. Again, doctor mentioned that he's good with blocks. Again, that tells us that he's good at pattern learning. In preschool, he is good in academics. So what is academics in preschool? ABCD, writing 1, 2, 3, 4, drawing lines, standing lines. Probably that also could be pattern learning. But limited peer interaction is the most important part, only after which you will write what I've written earlier, which is a poor social interaction. So if a child has poor social interaction and a speech of few words, that is delayed speech. If he has poor social interaction and mainly repeats alphabets and rhymes, then that is echolalia or pattern learning. The key message that I would like to share with our friends is, this is not a disorder. These are the symptoms. Seizures are not the disorder like our friend told us. There is an etiology behind it. So the question is, should we treat symptoms or the root cause? Because my friend Dr. Shambhavi mentioned that somebody had already started speech therapy to help this child with his delayed speech. But please remember, friends, that what you're doing is treating the symptoms. You're giving paracetamol for the fever. You're not finding out whether it is malaria or typhoid. So whether you need to give an anti-malarial or antibiotic. And hence, the question is, what are the root cause of these symptoms? Now, at this point, I'll share with you what is my work or my opinion about these things. So you can, take it as completely my point of view. What I have seen across 22 years in my career in development in pediatrics is the first beginning clinical point of all these symptoms in a child is there are some children who are poorly attached and poorly connected or poorly interacting, poorly engaged with humans, but are too engaged or too attracted towards objects. So I call this very simply Ati Vastu Maganata or Ati Vastu Maganta or and poor Manush Maganata, which means this child does not attach or engage with humans enough. Hence, this child does not learn how do humans behave. For example, bell बजेगी तो मम्मी जाके दरवाजा खोलती है, bell नहीं बजेगी तो नहीं खोलेगी. This is behavior. When to open the door, when not to open the door. And this the child can learn only when he's observing the mother. That develops the brain by 9-10 months where he can now understand non-verbal communication. So waving and pointing. And after the child understands all this, the neuroplasticity goes ahead when the child can understand speech by 1.5 years. And after that, the child can learn reading and writing. But if the first step fails, that is the child is not paying attention or not engaging with humans, all the other steps will fail. So he will not learn human behavior, what to do where. So he'll appear to be hyperactive. He will not learn use of gestures and pointing, and he will not use speech or not learn speech. At the same time, from objects, he learns patterns because he's observing objects and all objects are arranged in or run in patterns. So this child becomes a pattern ustad. And if you keep saying, say mama, say mama, say mama, the child may repeat, say mama. Or say good morning, say good morning. The child may repeat good morning, but that's parrot speech or echolalia. So what should the primary pediatrician tell the parents? Simple. Tell the parents, don't focus on symptoms and symptomatic therapies. Don't only focus on giving paracetamol for fever. Focus on the underlying cause. And to improve the underlying cause, please tell the parents, increase the human engagement with the child. It doesn't only have to be the poor mother who has to do it. Any human being is good enough, but decrease the object and pattern learnings. So I'm completely against the shape sorting and solving riddles, puzzles, and color mapping, and reciting number names and reciting rhymes and alphabets and writing alphabets. So tell the parents to decrease that and increase one-on-one engagement with the child. Some simple issues. What is the role of screen time? It's very well debated. Please remember that screen is the most fascinating object in today's world. So the child who's already object involved is going to get completely driven towards this object. And that is what to learn repetitive and pattern behaviors. Because on the screen, what do you have? Those same videos, the same way of doing it. And it even takes you further away from human engagement. Parents ask you, what is the role of school? Shall I put my child in school? It's simple. School is inappropriate until the child can handle himself, herself well in multiple social situations without a caregivers. Can he go to the chacha's house and stay with the chachi? Can he go to the mommy's house and handle the mummy? Can he stay with the masi and handle the masi? If he can't do that, unlikely that he can handle himself in school, but also need to tell the parents that school is not the solution for human engagement. Parents आपको बोलेंगे अरे वो बच्चा घर में इंटरेक्ट नहीं करता है तो प्ले ग्रुप में बहुत सारा इंटरेक्शन करेगा. जो माँ के साथ इंटरेक्ट नहीं कर सकता है उसका इंटरेक्शन में प्रॉब्लम है. ज्यादा लोग देने से नहीं होगा. इट्स लाइक सेइंग स्विमिंग पूल में बच्चा स्विमिंग नहीं कर पा रहा है तो दरिया में डाल दो तो बहुत सारा पानी है. यू नो व्हाट विल हैपन. सो टेल देम दिस. Finally, they'll ask you, मेरे बच्चे का autism का severity कितना है? So I'll tell you, tests have no correlation with the ultimate outcomes. So finally, two things, like Shambhavi has said so far, the effect of unplanned interventions is actually harmful because in this case, you will get mama bolo, papa bolo, good morning bolo, good evening bolo, hello doctor, how are you? ये सब पैटर्न लर्निंग करके बच्चे आते हैं. वो एक्सेंट भी वो थेरेपिस्ट का या उसका टीवी का या यूट्यूब का होता है. You will get this echolalia and robotic behaviors. The child, as long as you carry the shape sorting device and you carry some games, the child will sit quietly. The moment you take it away, it's like sharab. Sharab hata doge to bagdad macha dega. The moment you take it away, he's going to start having a problem, which means he has not learned sitting tolerance. He has only been given the object of his affection to keep him occupied. And the key issue is he can never manage without the mother or the caretaker. You ask the mother, can he go to the Masi's house on his own? He says, nahi, मुझे हर चीज में करना पड़ता है. So finally, what should you monitor? When you advise a child, parent all this, keep following up the child. Two things. Is the child better at his human engagement? Is he now looking at the mother better? Does he have better eye contact with people? Is he responding to name call better? Is the object interaction lesser? Is he less obsessed with objects? If you find that after you are coaching the parents on this and the parents trying it, it's still not getting better, then you need to refer the child to a developmental pediatrician who understands all this and then plans the intervention. So Dr. Shambhavi, I hope that's answered most of your questions.
Right. Thank you. Thank you, Dr. Sameer. Can I share the screen? Yeah. Thank you for, I think you've really highlighted a very core issue where when we talk about referring a child with autism, which we are seeing a lot of the general pediatricians are also seeing a lot. And we have to understand what are we looking at when we are referring a child with autism? Are we just looking at the pattern speech, what you talked about, or are we wanting a holistic and a independent functioning of the child in different social situations? So I think the key area is what Dr. Sameer also emphasizes, when we cannot start with the verbal part of the speech part unless the pre-verbal skills of the child are in place, which are essentially the engaging with the caregiver, looking at the caregiver, following few instructions, playing with the caregiver. And we have to understand this pre-verbal to verbal sequence of development has to be there when we are managing a child with autism. And straight away, we start with the verbal part and the child may start picking up those patterns which we just discussed about. Then the same child who presented to us in the OPT would look like, child ABCD तो बोल देता है, but वो हमारे साथ खेलता नहीं है, हमारी instructions follow नहीं करता है. And this comprehensive plan and monitoring can largely also be done by a pediatrician, but if they feel no, they need more, the developmental pediatricians are also there. And the role of families is to be highlighted, because if a child is spending 2 hours in a therapy center, the rest 22 hours are at home. And unless the parent is managing the child at home and engaging with the child at home, the child is not going to learn. So the role of parents and the immediate caregivers is very important when we counsel the families. So thank you, Dr. Sameer, for that beautiful presentation. So moving to our
Thank
case,
you, Dr. Shambhavi.
Moving to our fourth case, this is a child who is 4-year-old who was attending a preschool and nursery. And the parents have come to a pediatrician with the complaints that the child is not sitting in the class, he always appears on the go. Instruction following, simple instruction child can do, but if you do multiple instructions together, the child is not able to follow. Child can though identify most of the alphabets, but is very reluctant to write. And there is a history of a language delay. The child started speaking a bit late, single words by 2 years. Child can now speak in few sentences, but child is not able to sustain conversations. And the birth and the other development histories were uneventful. So I would like to invite Satinder Walia, who's a child psychologist at B.L. Kapoor. Now, how do we proceed here, Satinder? What factors do we need to consider if the child also seems to be hyperactive? Is there a role of occupational therapy outright? Is this ADHD? And what do we need this child? Do we need to follow up for any other learning disorder later in life? So over to you, Satinder.
Yeah, Dr. Shambhavi, I think we've covered a lot of, all the speakers have talked about the role of early intervention. And I think Dr. Sameer just talked about that rather than only treating the symptoms, we should look at the underlying features. So looking at the case, what you have just presented, from Murli, what we are getting is a lot of maybe sensory input because the child is on the go. So hyperactivity is there, but we don't know what could be leading to that. The child is following simple instructions, but that could also be a pattern learning that what we just talked about. the complex instructions the child is not able to follow. Again, identify most of alphabets that we have learned that is also becoming more and more visible these days. Children are coming, they actually are very good in the memory, especially the early symbols. So early knowing the rhymes, knowing the ABCD, knowing the numbers, backward counting, all these are very memory based, rote memory kind of a learning. So many of our children, especially who are also on the spectrum, are very good with this pattern learning, and they will repeat, they will echolalic, and they learn these symbols very fast. In fact, many of the children on the spectrum are also hyperlexic. So they are able to learn and they can read very fast, but they may not know what is the underlying meaning of that. Now, this child has a history of language, so there is some single words, but now is speaking in sentences, but is not able to sustain conversations. That's another important aspect to look at, because again, having a speech and language is not enough, because ultimately aim of speech and language is to hold conversations, to communicate with others. So if the child is not able to sustain conversations, goes on a tangent, talk on one topic again and again, that also, and has poor pragmatic skills, also we need to look at what is the cause of it. Is it a social communication disorder? Is it also something which is a spectrum? Then we come across the other factors, which could be a factor of hyperactivity, ADHD, or it could also be early signs of learning disorder. So these are foremost kind of a thing. Until and unless we dwell further, we do observations and take more history, it will be difficult to rule out any of those. So I think as a clinicians, what we all need to do is, what we just learned is that treating the symptoms itself, it doesn't help, because many times parents go from one place to another, and once they start therapy, just because knowing that, okay, there are delays is one part of knowing, but then knowing what could be the cause of it is the second aspect, because the intervention techniques may differ from a child with autism and the child with ADHD and the child with learning disorder. Having said that, the ultimate idea is to have early interventions only. So many times we've seen that what we repeatedly are talking about, we have seen that children who have high exposure to screens, and I think anybody who's working with children have seen, especially after the COVID, that screens are becoming more and more menace. And actually parents don't know that, it is not doing and it's being counterproductive. And this can be seen across. It's not only in the cities or from the small towns or even in the villages. Parents think that screens are they are giving exposure to a learning environment. So having the exposure to rhymes or having a ABCD. So I think there's a holistic knowledge to the parents which needs to be imparted, that language building is not coming across through the screens or Alexa. Human nature and human stimulation is the most important aspect of child development, which unfortunately we are taking away. And once we are taking away the human stimulation, we are also taking away the early social emotional learning. So children have got so hooked up looking at the screen. And I personally think if you are looking at the virtual, everything looks so beautiful. Why would you look at the human faces? They are so boring in nature. So we actually are training our kids to, from a very early on, look at that world, which is very artificial. And, no apps will not take care of the lap. So we see less stimulation from the parent side. Parents are not interacting with their children. There is no reading which is happening. We can start reading to children as early as 6 months of age. So if children are not exposed to the language, then of course language building will get impacted. Secondly, which I see, there's a lot of fascination, especially in our country, to send children to school. They should get fitted in the school. So even if my child has delayed development or language is delayed, we are very fascinated. School जाता है, पढ़ाई में सब कुछ अच्छा करता है, इसको सारा ABCD आता है. And as again Dr. Dalwai just said, I corroborate that at early years, learning is all about ABCD, knowing symbols. So if a child is able to know symbols, we just tend to think that the child is actually bright and doing everything, but which could also be a symptom of some underlying challenges. So sometimes if it is hyperactivity or if it is sensory overload, then just starting the occupational therapy itself actually can help building up the language. I think Dr. Shambhavi, you know more because you do interventions at your clinic with the OT interventions. I think OT has to be much broader. It does not have to be only in the center based. A lot of schools, actually preschools, have started inviting OTs as a consultant and having a sensory diet and a sensory how to manage sensory overload in the class through the teachers. And as we say, therapies are just one part of a child development. The therapy has to be a continuous process. So parents have to be part of it until and unless they are made how to interact with the children, how to be part of development of language, we will not be able to kind of sustain the intervention quality. Now, this can be ADHD, but it is also very likely that children may be misfit in the classroom, because sometimes you could be a younger in the classroom or older in the classroom. Sometimes they could be sensory overloaded, so they may not be learning in the classroom. Sometimes the way this is going, this looks like some of the ADHD symptoms, but again, many times I've seen that teachers get hooked up with the diagnosis of ADHD, and I think there is a more knowledge to be imparted that ADHD is a condition which needs to be managed and not to be treated. So just diagnosis is one aspect of it. How to manage needs a lot more awareness and lot more training among the community as a large. And definitely learning disorder needs to be kind of looked at, because the early sign of language delay is one of the early sign of learning disorder. And it's all related. As you talked about that, apple is different from ball, and then ball itself goes to a separate sphere formula. So I think what happens is usually when we focus too much on the academics, we forget about until and unless my child's language milestone is not well built, the literacy automatically will get impacted. And literacy is a whole lot of thing. It's not only reading symbols, it is also the comprehension. So language as a whole needs a lot of stimulation from the home environment, I think, the most. And more awareness needs to be done among the parents, because maybe somewhere we are adding to more sensory challenges to our children. And also because of the lifestyle changes, less of the going out, playing, and play is going out, like the expectations from a 3-year-old to do the writing, whereas we don't see that writing is a appropriate developmental skill at 3 years. So judging the children at that point for learning disorder might be too harsh. But yes, delayed in language could be a precursor of learning disorder.
Yeah, thank you so much, Satinder. And I think you rightly said the idea of putting this case was because in our development OPDs, we see a lot of these children being referred as ADHD. The parents are quick to jump to that diagnosis. The teachers are also in a way. But like you rightly said, we have to understand the influence of different environmental factors, the routine of the child, the screen time of the child. We have to do a little more detailed assessment, whether it is fitting into any other disorder. And of course, the expectations for the late age level of the child. If the child at 4 years is not writing, it's not really a big deal. But we don't have to go into one aspect of it and start managing it. Like you said, we have to see the total picture and what is the clinical presentation of that child in toto. And language delay, each and every pediatrician should keep in mind, like language delay in early years can be a precursor of a learning disorders in later in life. And we have to keep our eyes and ears open. So I think the summary points of the whole panel is like when we talk about a development screening, we don't focus on certain areas only, or the concern which the parent has come up. That is primary, but we have to also screen the whole development as a pediatrician of that child. Vision and hearing are a prerequisite for any child who has presented, whether it is autism, whether it is learning disorder, whether it is ADHD. We have to document a normal vision and hearing. Basic knowledge of simple screening tools like MChat or Trivandrum development screening tool or language evaluation screening tool Trivandrum can be there, which is very going to be helpful. And red flags of language delays. So if I talk about red flags of language delays, if there is no babbling till 1 year of age, no meaningful words till 18 months of age. And by meaningful word, I mean a meaningful word, not like just mama, mama, where the child may say mama to each and every one, but addressing mama as mama or pani as pani. So this is the meaningful word which the child would start doing at 1.5 years of age. A good word vocabulary of up to 15 to 20 words by 2 years of age. Child is not joining two phrases like mama do, pani de do, bahar chalo by 2.5 years of age. These are the red flags of language delay. And what I wanted to highlight is not only about the spoken language, but about the pre-verbal skills. So what are the red flags which we see about not being achieved in first 18 months of life are no social smile by 3 months of age, or limited social smile, limited to and fro interactions between the caregiver and the child at 6 months of age, not having a joint attention or a response to need. And by joint attention, I mean a child who is at 9 months and a mother is giving a rattle to the child will look at the mother and smile, and child will also look at the rattle. So there is a understanding that this rattle or this toy is being provided by the caregiver. So this jointly attending to an activity the child starts developing at 9 months, which is a very, very important pre-verbal milestone and is often lacking in children with autism at 9 months of age. No babbling like ba 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 ma 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 by 12 months of age. Not following a simple command, कि ये bottle papa को दे दो और ये वहां से ले आओ. Simple command like giving an object by 15 months of age, and not pointing for their needs. If they want water, they will often get the bottle themselves, but they will not point it. Or if they like something, they will not show the parent pointing it. So these are the pre-verbal skills, and if they are not present, then we are missing a lot of children, and we are probably also missing out intervening at that point where a lot of things can come under control. And last but not the least is the role of pediatrician is not limited to diagnosis or referral, but I think I would say it is DDD, which is monitoring, inform what you can monitor at your level. Maybe if you don't have knowledge about the autism interventions, you can at least monitor the development skills of that child, which again covers the holistic development. Start documenting what you are seeing in each visit. And you are the doctor, not of the child, but also of the family, and counseling parents about what to expect. We mentioned about what are the immediate things which we have to start on pre-verbal skill or verbal skills. So all those things are also very, very important. And just to highlight the role of parent, what they can do, I have just two short videos which I would share. This is a child who was 2.5-year old child, again coming from a little not a very strong economic background, but the child parent took some intervention and started doing work at home. And the child was referred as a child on spectrum, but within 2-3 months, the child started improving. And this is in this video, just see the pre-verbal skills of the child now. Can you hear the voice?
Yes, we can.
Bye. Bye. अच्छा साइन किस सकते हैं? पापा को दे दो, पापा को दे दो. Right. So the pre-verbal skills have formed well, and the child is definitely doesn't look like on spectrum now. And another parent who has a child who had a global delay. In fact, Dr. Rajni had seen this child also, and the child is from Kashmir, took few interventions, and the child is doing now, not only the child came with just single word speech and a lot of social anxiety, but the parent had really worked understanding the program, and now the child is in Srinagar.
Are you the class representative today? Okay, start.
So again, she became almost like a class monitor here and doing well in her class. No social anxiety, adjusted well. So these are the things which the parent can do a lot at their end. And I think thank you all for joining today. And if we have any questions right now, we can take up. There's still a couple of minutes.
Thank you so much, Shambhavi ma'am, for this interesting, very holistic approach to children with language delay. I think we managed to cover all the important points, which I'm sure all pediatricians are seeing in their clinics. And are there any questions? I request all the participants to please type their questions in the chat box, and we'll ask the questions to our specialists.
I think there's one question on Landau-Kleffner syndrome. The chat box. Yeah, I showed the indications for EEG in a case of language delay. So yes, this will come. In a child with speech regression, obviously would come as a indication for EEG. But in my OPD practice, Landau-Kleffner is very rare. And Rasmussen's encephalitis will have other features as well as mentioned in the question. But yes, language regression may be because of multiple reasons, maybe because of screen exposure, maybe because of less stimulation, or maybe because of social anxiety. So multiple factors are there for language regression, but EEG should be done in these cases to at least rule out epilepsy.
Is this the recording? Yeah, you have just mentioned on YouTube.
So I think there are no more questions from the audience side. Thank you so much to all the panelists. Let's wrap up this meeting. Special thanks to Dr. Sameer, who could join us all the way from Bombay. Thank you for taking out time from your busy day. And thank you so much, Shambhavi ma'am, for giving us such a nice holistic approach to children with language delay. And a very warm, okay, we have
We have
one
one
last
question, Dr.
question.
Ritika.
Which tool can be used to diagnose autism before 2 years of age?
So there is a screening tool which we have, which is the MCHAT, which starts from 16 months of age. And before that, we also have a CSBS-DP, which is the Cognitive Symbolic Behavior Scale, these are the tools which are freely available. So these are the screening tools which focus more on the communication and the pre-verbal skills. So, but again, they are not diagnostic, right? The diagnostic will be more of a clinical assessment before 2 years of age, because most of the diagnostic tools which are available are after 2 years of age. But with the help of a screening tool and your clinical assessment, you can definitely, I think, even if you feel very strongly it is autism, you can, but even if you don't want to, are not sure, you can definitely start intervention. So the key message is not really about the diagnosis, but also about to start the interventions and not wait for the diagnosis to be made and then start the interventions.
All right. So thank you to all the participants, all the delegates who attended this meeting. I hope this 1 hour was fruitful for you guys. And this is me. I'm Dr. Ritika Goyal from Pediatric Pulmonology at Center for Child Health, PLK Max Super Speciality Hospital. And I'll sign off on behalf of our whole department. Thank you so much for joining us. We'll be coming back with a yet more interesting topic in 2 weeks' time. Thank you so much. Have a very lovely day.
Thank you, everyone. Thank you, Dr. Ritika. Bye-bye.
Bye. Bye.